Good afternoon. We'll be continuing with the same chapter, diagnostic aids in endodontics. This was, if you see the slide, it is the same questions that I was trying to explain you yesterday. Uh, the location, duration, the positive factor, aggravating, relieving factors. These are all the questions. We stopped at something called as the pulp vitality, and just a sec. Okay, this is it. So, vitality means that the pulp is alive with blood supply. Uh, Example could be if you give local anesthesia to a particular patient, the tooth becomes insensitive to pain. That means it is not non-vital. It is vital only because the blood supply is still going on. So even though the vitality is because of blood supply, we still do heat testing and cold testing because the blood supply, if there is any change in blood supply, it will cause a certain damage to the surrounding nerve fibers, and this damage is picked up by cold testing and heat testing. But cold testing and heat testing is not the only pulp vitality test. Pulp test can be, as you can see on the screen, they are thermal test, that is cold test, heat test. Then there is electric pulp testing, test cavity, in which you prepare a cavity. We'll be discussing that later. Then there is anesthetic testing, bite test, and there are other recent advances in pulp vitality testing, including laser Doppler flowmetry, pulse oximetry, trans illumination with fiber optic light, dual wavelength spectrophotometry, liquid crystal testing, the Hughes probe by camera, and 133 xenon radioisotope, in which you don't have to actually, you just have to remember the names of this. But the laser Doppler flowmetry, that is if you see the paragraph of recent advances in pulp vitality testing, the laser Doppler flowmetry and the pulse oximetry, and maximum is trans illumination with fiber optic light and dual wavelength spectrophotometry. These are the four that you will have to learn because they are asked in the exam. Heat test, basically heat test is nothing but if there is a particular suspect tooth that you have shortlisted after the intraoral examination, then what you have to do is isolate that particular tooth and do the heat and the cold testing. Now, how do you do heat and testing? Is first is hot air, hot burnisher, hot gutta percha sticks, hot compound, and polishing of the crown with a rubber cup. Now, rubber cup is placed into a straight handpiece and it is rotated at a high speed. So once that rubber cup touches the tooth, heat is generated and the heat testing is done. Common method employed is one with gutta percha stick. Gutta percha stick is heated over an alcohol flame until it becomes shiny and soft, and it is touched onto the middle third of the facial surface or the buccal surface. If the patient doesn't give you a response when you touch the heated gutta percha, the same test is performed on the cervical region, but you have to be very careful that it should not touch the heated gutta percha, should not touch the gingiva. Just a sec. Right. Now, there is a particular temperature beyond which the pulp will not be able to sustain that damage. That is, it should not be more than 60 degree Celsius, and otherwise there can be a necrosis in the pulp. Right. This is an photograph of, if you see the first photograph where the arrow is, the gutta percha stick is being touched to the middle of the facial surface. This is another picture which is showing a gutta percha stick. You see there is an air rotor there. That air rotor has a rubber cup which is rotating at high speed. Air rotor rotates at around 1 lakh to 2 lakh RPM. So just imagine how much heat that must be creating. And then there is a wall varnish you can see. And finally, if you see, the tooth is isolated in a rubber dam and a hot water, coffee hot water is poured onto the tooth surface. This is an age-old technique. Cold testing, the agents that are used for cold testing, if you see, happen to see, the cold test procedure is same as that of heat testing. Isolation is very important, and cold testing can be done with cold air from a three-way syringe or an ice stick, ethyl chloride spray, or a frozen carbon dioxide. It is basically dry carbon dioxide or carbon dioxide snow or carbon dioxide ice. also called as dry ice. Refrigerant spray, that is 1112 tetrafluoroethane. Again, you have to remember these names because it's an MCQ question. And then cold water can be used. These are the pictures of every known cold testing agent. If you see here, there's an ice stick which is used at the bottom right hand side. Then you can use a stick of dry ice, that is carbon dioxide snow. You can use difluoromethane, which is most commonly used. The first and the second picture on the top are the ones which are locally available in the market as well. And finally, you see it's a rubber dam napkin is placed with the rubber dam obviously, and a ice cold water is poured onto the tooth surface. Now, isolation is very important in both heat and cold testing and even all vitality testing, because let's say you are pouring hot water onto a particular patient's tooth and you have not used a rubber dam. The hot water will touch the other teeth and also it will burn the gingiva and the teeth and the cheeks and the floor of the mouth as well. So that is why it is very important that you use rubber dam in heat testing. Why to use a rubber dam in cold testing? Because if you are pouring cold water onto a particular tooth surface and it is not isolated, that particular cold water will touch the other tooth, and other tooth will give you a false positive or a false negative response. I'll tell you what is false positive and false negative. You must have heard this term with respect to coronavirus testing as well. False positive means that particular case is not positive, but still when you test it with cold testing or hot testing, it will give you a positive result, and but it is not. That is why it is called as a false positive result. And false negative means the tooth is alive, but the testing gives you a negative response, and that's why it is called as a false negative uh, result to the testing. Okay, this is an electrical test. If you see the topmost picture, whereby you can see there are various components to an electric pulse tester. You see there is a rectangular uh, unit which has a digital kind of meter, whereby the amount of current flow through the electrode is noted. You see there is something curved. This curved tip is called as the this is the one which will provide the current to the tooth. This tip is covered with an insulator. You see that it's covered with a black sheet. There are two electrodes basically. This particular electric pulse testing unit is attached with a wire which has a hook. This hook will go and engage the patient's cheek, and eventually you will pass a current to the patient's tooth and you will get a response. Most importantly, you will have to explain the patient that a current is being passed through your tooth. Otherwise, patient can take you to the court as well. If you see, this is a technique. First is describe the test, as I said, to the patient. That will reduce the anxiety, because half of the time the patient will be very much in pain, and that is why you have to explain that you are reproducing that pain using vitality testing like electrical test. You have to isolate the area. I have been explaining this again and again. Isolation is very important. Suppose you are using an electric pulse tester on a upper central incisor and it is not isolated, then that current will flow to the other central incisor and lateral incisor as well, and because of which you can get a false positive or a false negative response. So this is very important. You have to check the electric pulse tester for function and determine that the current is passing through the electrode, and then the electric pulse tester is technique sensitive. The tooth to be assessed should be sufficiently dry to prevent, obviously I have told you this, it should not the current should not pass to the adjacent tooth or the periodontium. This is how now every electric pulse test is provided with an electrolyte. Without the electrolyte, the electric current will not flow. And in this case, the electrolyte is a common toothpaste. This toothpaste is applied onto the center or the middle third of the buccal surface of the tooth in question, and then that electrode is touched onto that particular tooth surface where the electrolyte is applied, right? The doctor who is holding the electric pulp tester in his hand ideally should not wear gloves, so that gloves are a bad conductor of electricity. So if you wear gloves, the electric current will not flow through. But nowadays, because of increasing transmission of infections, you have to wear gloves, and because of which you will have to hold a metallic instrument in your hand, and hence the circuit will be complete. I don't think so they have a picture of this. These are all the pictures of the electrode touching the tooth surface. Right. Now, this is an explanation of false positive result. False positive means they are negative, but they are giving you a positive response. Let's say the first example, anxious patients. Now, anxious patients are always experiencing pain. So, if you tell patient that such a patient that you are going to pass a current through your tooth, they will always give you a positive response even before you touch an electrode onto the tooth surface. Even when the tooth is dead, they will say, "Nahi, I have pain," and because of which you get a result which is called as a false positive result. If there is a liquefaction necrosis in the tooth, the necrotic material is liquid in nature. The liquid is a good conductor of electricity. So even when the tooth is dead, you will still get a response from the tooth, and you will feel that the tooth is alive, no treatment is needed. This is also a false positive result. Contact with metal restorations. Obviously, metal is a good conductor of electricity. So if a metal cap is present over a dead tooth, the patient will have pain because of the metal, and hence it is a false positive results. Again, if vital tissue in a multi-rooted tooth, if the pulp present in, let's say, a mesiobuccal canal of the tooth is necrosed, but the pulp present in histobuccal and palatal is still alive, then it will always give a false positive result because of them. So you have to be very careful. Again, this is false negative result. False negative means the tooth is positive to start with, but the patient is giving you a negative response. That means even whatever be the amount of current flowing to the tooth, the patient is not giving you any pain response. That is false negative result. These are the examples: incomplete root development, recently traumatized teeth, sclerosed canals, recent orthodontic activation, and patient with psychotic disorder. Okay, next is anesthetic testing. In anesthetic testing, what you have to do is you are not able to make out whether it is a maxillary tooth or a mandibular tooth that the patient is complaining because of deferred pain, and in which case you will first anesthetize the patient with inferior alveolar nerve block. Obviously, patient will tell you if it is paining on the right or the left side. That is very easy, but you don't know whether it is maxillary or mandibular. In this case, you will have to inject the patient with inferior alveolar nerve block, because of which the mandibular area, right or left, will get anesthetized. And in this case, you have two options: either the pain will go off, in which case you will know that the pain is mandibular in origin, or the pain will still remain, in which case you will know that yes, the pain is maxillary in origin. If the pain is mandibular in origin, you will allow the anesthesia to wear off, and then you will infiltrate individual tooth in that particular quadrant, right from the third molar and come back to the anterior, and then accordingly diagnose the correct tooth. If the pain is in maxillary, again you will start infiltrating the from the upper third molar and then come towards the central in that quadrant, and this way you will come to know which tooth and which quadrant is involved in the pain. This is anesthetic testing for you. Test cavity is used in the cases where pulp vitality testing has not given you a result, the anesthetic testing has not given you a result. In this case, you will start digging a hole inside the tooth, and without any coolant. Now, this has to be done at high speed. High speed means air rotor speeds, and you are not supposed to use any coolant. Once you cross the dentino-enamel junction, in that case, it will always, the patient will always give you a response, and this way you will come to know whether the patient's tooth is alive or not. Bite test. This particular bite test is done to find out whether the patient is having any crack inside the tooth or not. Now, if the patient is having a fracture inside a particular tooth, when the patient bites on a cotton pellet or a particular instrument like this is called the tooth sleuth, SLOOTH. Whenever the patient bites on this, fracture tooth will always pain. But if there is a crack present in the tooth, patient will always complain of pain when the biting pressure is released. Patient will bite on this, patient will not have pain. But when the patient releases the bite, he will have pain whenever the crack is present. This is one thing that you have to see. Laser Doppler flowmetry. This is a little confusing for you guys. What is done is, I'll show you the previous picture. In this, I'm sorry, yeah, a laser light is passed through the tooth in two frequencies, and there is a sensor which will catch hold of that particular laser, and accordingly you'll come to know whether the tooth is vital or not. It is explained in a little confusing manner in the textbooks. Whenever the laser passes through the pulp, the pulp obviously has blood supply. Blood means there are presence of red blood cells. This red blood cells will absorb the light in the capillary plexus and are scattered. And this light is scattered obviously and undergoes a change in frequency which is noted by a sensor. And this way you will come to know whether the tooth is vital or not. Because if it is vital, there is a particular shift in the frequency. If it is non-vital, there are no red blood cells, so there will be no change in the frequency. This is the way you come to know about light Doppler flowmetry. Sorry. Okay, pulse oximetry is a test which will measure the oxygen saturation levels within the blood of the patient. This pulse oximeter is nowadays used to detect the coronavirus patients also. It is used in the clinics to note whether the patient is having sufficient oxygen saturation level within their blood. This is used, obviously pulp also has blood, and this is in a way used to note whether the pulp's blood is having any oxygen carrying capacity or not. This is the only thing which is done with pulse oximeter. It is successfully used for measuring the vitality. Again, dual wavelength spectrophotometry. This is used in the same way that of laser Doppler flowmetry, whereby a dual wavelength light, that is 760 Newton meter and 950 Newton meter, is passed onto the tooth to determine the oxygen saturation levels. And the process is the same. The other things are not for you. These are for postgraduate students. Sorry. Okay. Now radiography. So if you remember yesterday, I was telling you that there is a visual examination, there is a tactile examination, and then you have a radiographic examination. A radiographic examination is the part of an investigation. Always when you write down case histories in oral diagnosis, you will always write down provisional diagnosis, and then you will write down investigations. There you write down IOPA. This is a photo of an OPG, orthopantomograph, and ultimately you write down the final diagnosis. Not only radiograph is important for diagnosis, particularly with response to caries in the crown, whether there is a filling in the crown, whether it is treated for root canal or not, but it is also used during the root canal treatment to find out many other things, whether the process of root canal is done properly or not. Always whenever you are assessing any kind of an IOPA or any radiograph, you'll have to start from the crown of the patient and then proceed ahead to the root and the pulp, and finally you will see the lamina dura is intact or not, and whether there is any periapical changes in the bone or not. These are some things which you'll have to understand while you are checking the radiograph. Nowadays, after radiograph, you also have this is an ultrasound. It is same ultrasound which is used in hospitals, which is used to find out whether there are changes in the alveolar bone or not. Nowadays, you have, I don't think it is there. Okay. Uh, Whatever x-rays or radiographs that we take into the patient in the patient's mouth are basically film based. You have a radiographic film, you put it in the patient's mouth and you develop that film. It's like a photograph. But this radio videography that you see on the screen right now is basically a part of the just a sec. This is a part of digital radiographs. You all know what is an RBG. This is a machine to which this sensor is attached, and this machine by this plug is attached to the laptop. or PC, or it is nowadays attached by Bluetooth to the tablet as well, and you will get digital images like this. If you see on the left hand corner, there is a digital image of the X-ray. This is very important discovery in dentistry because you are now able to store the digital images for your own in your own laptop. You don't have to store films, right? Most importantly, the advantage of the RVG is that the radiation dose is reduced, absolutely reduced. Normally, if you are using an IOPA, you will shoot the IOPA for half a minute. But in this case, the in case of an RVG, the X-ray shoot only for 0.04 seconds or 0.03 seconds to be specific. Whatever is the image, you can always edit that image. On the contrast can be adjusted, the brightness can be adjusted, because of which you save time uh, while taking an IOPA with RVG. So now for you, this will be taught to in oral diagnosis. Yeah, computerized tomography. Now, computerized tomography, that is CT scan, is nowadays called as, I'm sorry, nowadays called as CBCT, because CT scans we don't do for teeth. We use a CBCT, that is computed tomography, but for the teeth. You will not learn this right now. This will be taught to you in detail in oral diagnosis. Basically, photographs or radiograph, these are two-dimensional pictures. But whenever you take a CT scan or a CBCT scan, it is always a three-dimensional picture of a particular tooth, and hence that will always give you more definite and a specific picture of a particular tooth. Now, computed tomography or a CBCT is always used for determining the buccolingual and mesodistal width of the teeth, presence and absence of root canal filling materials and metal post. They are used to judge the extent of carious lesions, extension of the maxillary sinus and its proximity to the root surface. Advantages are obviously provides images for 3D reconstruction of root canals and teeth, observation of structures, and normally whenever there is a multi-rooted teeth, there is superimposition of anatomical structures, and you are not able to visualize what is present there. CBCT or CT scans will always provide you a three-dimensional picture, and hence will always show you the difficult to visualize area of a radiograph. Obviously, disadvantages are very expensive, and the dosage of radiation is large and it is time consuming, right? So, as I was telling you yesterday, the diagnosis is very important for treatment planning, and treatment planning is very important so that the patients understand that you are a good doctor. So, everything boils down to only one fact, that your diagnostic skills should be good. And how your diagnostic skills are good? They are not good because of radiograph or vitality testing or because of CBCT scan. They are always good because of a good history taking. If you can take a very good history, you are always 99% correct in your diagnosis. Obviously, 1% remaining are will be correct because of radiograph assessment and other tests that are being done. If your diagnosis and case history is correct, you will not take much time to become famous as a good dentist in your area. So, case history is a very underrated process in dentistry, particularly undergraduates. You'll have to learn a good case history procedure and a recording. And for that, I've already told you those questions which you had written down yesterday. You have to use those questions only to judge why there is always pain to the patient, even when you provide a good treatment. That's it. You can always post questions using WhatsApp, and I recommend textbook of Grossman to read this particular chapter. Any doubts that you have right now, you can ask me. Any doubts?
No, sir.
Okay, great. right? We'll meet on Friday now or later for the next chapter.